Now we call upon Dr. NEENA. She is senior consultant in Gridhar Eye Hospital, a very dynamic strabismologist. Over to you, Dr. NEENA.
Thank you, Dr. Fatima. And I'll be talking on tackling strabismic causes of abnormal head posture. So I'll be talking about both restrictive and paralytic head posture causes. So let's look at this case. He's a 21-year-old college student. You can see that he has a very prominent left face turn. And if you look at the video, you can see that there are some palpable fissure changes in the left eye on adduction, -3 abduction, and he has a left esotropia. So this is a classical esotropic Duane's retraction syndrome with left face turn. So he was concerned not about the squint, but about the abnormal head posture. So you can see this is his, we went ahead and did a weakening of the medial rectus in the left eye because he was esotropic, along with a superior rectus transposition to the lateral rectus to strengthen his abduction. And you can see here that his abduction did improve from -3 to -4 to about -2 to -1. And he was happy because his head posture was much better. So this is a SRT which is being happening, and we can augment it with non-absorbable sutures if you wish to strengthen further. So this is another case of a 7-year-old boy. He again has an abnormal head posture, a left face turn. He was ridiculed by his classmates, so he was not going to school. He stopped going to school. So his parents brought him to me. And again, you can see very small esotropia in primary position, but significant abduction restriction, -3, and palpable fissure changes are there. So we did the same thing, a medial rectus weakening of the left eye, along with a superior rectus transposition to the ipsilateral lateral rectus. And you can see the dramatic change in his head posture pre and post surgery. You can have a little more complex case. Look at this boy. He has a very prominent left face turn and also some facial asymmetry. And if you correct his head posture in the primary position, you can see that the right eye is hypertropic and esotropic, and he has an abduction limitation in the left eye and palpable fissure change in the left eye. So this is a left ESO-DRS, but fixing with the left eye. So the secondary deviation is manifesting in the right eye. Along with that, he also has a DVD, a dissociated vertical deviation of the right eye with inferior oblique overaction. So I'll show you a video. We first thought it was superior oblique palsy, but when you look at his video, you realize it is only a dissociated vertical deviation in the right eye. He was amblyopic also. So what did we do for him? His FDT was positive for medial rectus. We did a small medial rectus recession in the left eye and a larger recession in the right eye. Along with that, we weakened the inferior oblique of the right eye because he was amblyopic and he was fixing with the DRS eye. So you can see that post-surgery, his head postures improved very well. He was quite happy, and his squint also became much better. So this is another child. You can see she has a left face turn, and this time the culprit is not the left eye, it is the right eye. You can see in primary position she has a significant exotropia and an adduction limitation with palpable fissure changes and also an upshoot. So this is a classic exotropic Duane's retraction syndrome, and we did a lateral rectus recession with a Y-split of the lateral rectus in the right eye, and you can see she's much better, and the upshoot is also better controlled and a face turn improved. So sometimes you may have adult patients like this also coming to you with head posture. This lady has a thyroid orbitopathy, and she has a significant restriction of abduction in both eyes, more in the right eye. She had a large right face turn. And we just did an medial rectus recession. Also, she had some vertical strabismus, so I had to do some inferior rectus recession in the right eye. She's awaiting surgery in the left eye. She still has some ESO, but she's much better. So this was a 28-year-old painter. You can see the classical right head tilt, a left hypertropia increasing in right head tilt, increasing in left head tilt and right gaze. This is a classic left superior oblique palsy, very severe diplopia. So this is his head posture, and we did an inferior oblique recession of the same eye along with an inferior rectus recession of the contralateral eye because he had a very large esotropia, hypertropia of the left eye. So post-surgery, he was quite happy. His head posture was well corrected. This was a gentleman. He had a road traffic accident and he had bilateral 6-nerve palsy with very large ESO deviation of the right eye, and he had a right face turn. So we did bilateral medial rectus recession and superior vertical rectus transposition to both the lateral rectus, and this was one of the old cases which I did. Now I have shifted to either SRT or Nishida, but we did vertical rectus transposition to lateral rectus in both eyes, and he had pretty good cosmesis and improvement in his head position. So this 6-year-old girl came to us after an excision for pontine glioma and radiotherapy. So this is a corrected head posture. She has a very large right face turn and a large right esotropia. You can see both eyes, the abduction is limited. So this is after we gave Botox to the medial rectus. You can see improvement in her ESO. And finally, after bilateral medial rectus recession and an SRT to the lateral rectus, she's much better, head posture is better, though the abduction is not complete. This 5-year-old boy has a classical chin-up position, ptosis. This is a classic monocular elevation defect, a right hypotropia. You can see that elevation is -3. And we did a modified Nishidas for him, and his abnormal head posture and ptosis and hypertropia improved very well. So in Nishida, there is a no tenotomy, no disinsertion surgery in which you take bites with non-absorbable sutures from the horizontal recti and transpose it to the superolateral and supromedial scleral compartments. So this gentleman had a stroke in Pons, and this is what he developed, a left horizontal gaze palsy. This is him looking to the left, absolutely no movement of the eyes to the left. But he also had a true lateral rectus palsy or 6-nerve palsy. So very complicated strabismus. This was how he was earlier, and you can see after a medial rectus recession of the left eye and a superior rectus transposition to the lateral rectus, he's much better. Probably he'll need a second sitting in the right eye, but he's much better. So this lady had a CP angle tumor, a cerebellopontine angle tumor, and she had a combined 6th and 7th nerve palsy. You can see there is a very large ESO deviation and a facial palsy also. So what he did was we underwent and took her for medial rectus recession of the left eye along with a SRT to the lateral rectus, and also combined it with the tarsography. So she's better, though the abduction is not 100% there, but it is much better. She's able to read and write well. So in a nutshell, HP in a restrictive and paralytic strabismus could be to attain BSV, to prevent diplopia, or to increase the separation of the images. So the goal is to identify the cause and treat it, weaken the tight muscle, strengthen the weak muscle, or a combination of both, so that there is ocular motility improvement, reducing diplopia in primary gaze and enabling binocular single vision. Thank you very much.
Thank you, Dr. NEENA. I have a question. You have shown many SRT, right? What is your experience about vertical? Have you encountered any vertical?
Yeah. So, yes, I have encountered a few vertical, but young children did not complain because obviously they will suppress. But the gentleman with the pontine stroke, he had a vertical deviation, but it reduced with time. So he wasn't very symptomatic, but in one patient I had to give a vertical prism.
Okay.
So it can happen.
The SRTs you have shown.
Madam, mic is there, madam?
Yeah, there is a mic. The SRTs you have shown are all just SRT, or you augmented?
It depends. In DRS, I do not augment it, but in a 6-nerve palsy, depending on the angles, I augment it. But I don't augment with a scleral bite. I just augment them with the muscles. If you take a scleral bite, the chance of torsional diplopia is much more, as demonstrated by Mehendale et al. But it is your surgeon's, preference.
Okay.
One question, Dr. NEENA.
Yes.
In Ella palsy and also in DRS with abduction deficiency, what I prefer is Nishidas than superior rectus transposition to lateral rectus. I find that the lid fissure changes, the induced vertical deviation are all much less with the Nishidas than. What is your opinion?
Yeah, one of those surgeries in which I did VRT is a very old surgery, but I've shifted to SRTs, and off late I've started doing more of Nishidas. But I have encountered one problem. With Nishida, I'm getting some worsening of the horizontal deviations. Like I had a patient, this child with MAD, he had a small, he had an exophoria, just 16 prisms. Post-surgery, it increased to 25 prisms of exotropia. So I had to put him on patch. So there could be sometimes asymmetric tightening of the rectus muscle. So it's not a titrable surgery. So I think that's something I need to look at on a long term. But as you said, it is a more less invasive procedure and something that we have to consider and something we can easily do.
Have you experience of titrating? You were mentioning how would you always anchor Nishida in between supratemporal or infratemporal or more towards lateral rectus depending upon the deviation?
Yeah, so the thing is, Nishidas, I find that Nishidas gives you anything less than 25, Nishidas works very well. But anything more than 25, I do need a transposition, a true transposition surgery. So I think adjustable Nishida is also there, but I haven't tried it because most of the kids are small. So I think it's a good option probably to see how the adjustments are there. Your experience in this?
I have tried some, but I couldn't correlate. I will just take it more towards lateral rectus in case of larger angle, but couldn't arrive to a conclusion.
No, I've done Nishita, but I bring it close to the lateral rectus, but the same thing, 25 to just around 25, it's okay. Above that, it doesn't work that much.
Yeah, and more than 35, augmentation is better for a transposition.
There is about 25, we have to correct the medial rectus. No. After medial rectus, you do
along with medial rectus. Yeah, along with medial rectus.
But it is more than all these other things done.
Nishidas will only improve abduction. It won't correct the horizontal deviation.
No, along with medial rectus. But when the angle is more than 25, it's not very good.
And one more word of caution with the transposition is that very long-term results are not there. So there is always a chance for overcorrection. So I am very conservative with my medial rectus recessions unless it is very tight. So I do very small medial rectus because eventually some of them go for overcorrections.
And also for DRS, we have to always look for that anomalous LR activity. If it is significant, we should avoid transposition.
Yeah, there is a globe retraction. I think SRT is not there. You should definitely try a medial rectus, bimedial recession, more on the normal eye. That will be better.